Okay, so next up we have Professor Paul Fitzgerald. So Paul is a professor of psychiatry at the Epworth Clinic in the Epworth Healthcare, and he's also director of the Epworth Centre for Innovation in Mental Health. So Paul's going to be talking about clinical brain stimulation in the time of COVID, a very relevant topic at the moment. Thanks, Paul.
Good afternoon, everybody, and I'm quite aware of the time, so I'll do whatever I can to make sure we don't end up running too far over time. So I'm not going to really talk about any clinical data or research data, but just really talk a little bit about how we've thought about COVID, both in terms of its impacts, but also in terms of what we've needed to do to try to keep functioning across this time. Clearly, there are lots of issues related to COVID. I want to talk a little bit about, in general, to begin with, about COVID and mental health. We're going to talk a bit about TMS and COVID in the context of both clinical service delivery, but also sort of laboratory processes and the like. I don't think it'd be any surprise to any of you that we're living in a time that is likely to be having really major impacts on people's mental health, and this is now increasingly represented in the literature in general. There are lots of emerging papers describing the mental health implications of COVID. There is a couple of grant schemes, one specifically in Victoria and one going through the MRFF, to develop research protocols to look at how we can ameliorate some of these impacts. And there's been federal government funding for a variety of mental health programs. There's really a quite broad range of risk factors for existing patients in terms of worsening of their mental health and for the new onset of mental health conditions. And most of you will be well aware of these, both from your personal experiences, but also, from what you hear from family and friends and from the media as well. And certainly working in a mental health service, we've seen this. I rarely see a patient now where there hasn't been some relationship between the current circumstances and an exacerbation or evolution of their mental health problems. Our inpatient mental health ward, on our ward, we had a significant drop-off in admissions during the first wave of COVID, but mid-lockdown period, things turned around, and by the end of lockdown, we were full and receiving lots and lots of referrals. And we've pretty much got a mimicking of that at the moment, where there's been a bit of a drop-off. There's been some psychiatrists reluctant to admit and be around the ward environment, but lots and lots of patients who are requiring care. And some of that's been exacerbated by reduced access to timely care and support. Pretty much the psychiatric and psychological workforce transitioned very rapidly to the use of Zoom and other methods for treating patients, but in reality, it's just not the same. And lots of patients struggle with the interface. They struggle with the lack of in-person care, and that's really had a major impact for lots of people. The shift to telemedicine in primary care has also meant that there's probably poorer detection of mental health concerns and delays in referrals. The significant media focus on mental health, I think, is a good thing in some ways, around reduction of stigma, but also potentially creates an expectation about distress and illness in a way that potentially pathologizes normal grief reactions, normal sort of psychological reactions to the types of experiences that we're all going through. And clearly there's a major limitation around the effectiveness and engagement of patients in remotely administered therapy. We can do it, but the quality of this really varies across the board. So the likely outcomes is we have an increase in relapse rates, which we're definitely seeing. We have an increase in onset of new mental health conditions, which we're also seeing, but also those issues around the delay in mental health, in the timeliness of mental health interventions. In regards to brainstem, kind of where does this fit in? Well, TMS there's clearly issues around TMS because of the frequent attendance of patients at medical centres, hospitals, clinics, and the like. And that raises, issues around patients' ability to travel, especially if they're using public transport. now in Victoria, if they're crossing urban boundaries, it becomes an issue. And we've had to directly address this at the moment. At TMS Australia, we've got clinics in the northwest suburbs of Victoria, which overlap a couple of the places that were originally locked down in the initial hotspots. And then there's issues of maintaining adequate social distancing in the TMS room, issues for both patients and staff. So fairly early on in the first wave of the pandemic, we saw the need to develop some guidelines to try to address how we manage TMS during the COVID pandemic. I wrote a set of guidelines, and we actually had these processed through the Royal Australian and New Zealand College of Psychiatrists, and they basically didn't get, we sort of wrote these in late March, early April, and they didn't get approved for quite a long time after that in a way that we had thought had made them obsolete. But given the current circumstances, certainly in Victoria, there has been some value in going through the formal exercises of having these kind of stamped off by the college. But, and ultimately the goal of these guidelines is to ensure that in a clinical service delivery framework, we minimise risk associated with TMS delivery to staff, patients, and the community in general, whilst maintaining access for patients to what is an effective treatment that is likely to be more necessary under the current circumstances rather than less necessary. So some of the broad principles within these guidelines include the use of tele-facilities wherever possible for intake, medical assessments, clinical assessments, and the provision of patient information. So, the shifting of as much as what we can do remotely to do that remotely. But obviously we can't do the TMS remotely. So, we need to be implementing a series of procedures to ensure that we're screening staff and patients. So that includes things like temperature checks on a daily basis for both patient and staff. And we implemented this at our clinical site prior to their implementation of site-wide temperature checks before you came into the building, which kind of made it a bit easier because we could just hand that over now. If you walk in the front door of the hospital, you get your temperature checked. And having some standard contact and symptom screening process and modifying that so that we can do it on a daily basis. What is it? The symptom screening processes that the hospitals developed are really for kind of one-off visitations and don't really work so well if you're coming every single day. So we've adapted a variety of these processes. This is the Epworth COVID screening risk assessment form that gets done whenever somebody comes to the hospital, whether they're a visitor, a patient getting admitted, or a patient attending an outpatient procedure. So we go through this process with the patient on a daily, at the onset of their treatment, and then just score off each day that they attend whether they've got a temperature and specify whether there's been any changes in the 24 hours or, in the case of the weekend, the 72 hours prior to their prior attendance. We also need to do this for anybody who's attending a carer or support person who's coming along to support an individual patient with their treatment. And there have been incidences of a carer placing people at risk rather than a patient. As most recent as this morning, we heard about a case at another research site in Melbourne, not a brain stimulation research site, but where a carer in a medical research environment has now been identified as having been diagnosed with COVID a day or two after attending a clinical trial assessment visit with a patient, and that's resulted in quite a number of staff and around that medical research environment having to go into isolation. So what else in terms of the actual TMS itself? Well, we implemented straight away cleaning of all relevant surfaces and equipment between patients, so not just the coil itself, but the chair, anything, door handles, anything the patient's likely to have touched. Staff members will use hand sanitizer, basically before each patient and between any patient and administrative tasks. So they set up the patient, the coil in place, they need to use hand sanitizer before they touch the clinical records or the computer if the records are in electronic form, maximise room ventilation wherever possible, and maximise distance. So the clinician outside the room if possible, the treatment chair facing away from the clinician if possible, etc., etc. So really trying to do some of those plain, sort of practical things. Scheduling's important. We don't want patients sitting in waiting rooms, so it meant implementing less overlap between patients. So we might have a patient finishing at 2:45 and the next patient starting at 3 o'clock. So they can come straight into the room rather than sitting in a waiting area. And the bit that's probably evolved the most has been the use of PPE. We initially thought that using gloves and masks when performing resting motor thresholds would be reasonable, and implemented particularly the use of masks where patients and staff wanted to use those, more to provide reassurance than anything else. But certainly within our hospital environment now, where we do outpatient TMS as part of our clinical trials, as I'll talk about in a minute, that is, the use of masks in particular has become compulsory. So as a visitor into the hospital, you're given a mask at the front door, and staff are meant to wear masks with any patient-facing procedures. And so that includes TMS. So when I go and do a ward round, whether I'm doing a resting motor threshold, if I'm seeing a patient, I'm wearing a mask, and so are our TMS staff. We formalised some structures for, and we're also doing that in our outpatient clinic-based practices as well. So at TMS Australia, we provide, all staff wear masks, and we provide masks for patients when they come onto the premises. We implemented some formal guidelines to help to deal with what we thought was going to be a bit of an overwhelming number of patients who discontinued treatment early, or if they had treatment courses interrupted by clinics being shut down. We've been really fortunate that that hasn't happened on any occasions. There have been several mental health facilities in Victoria that have had significant problems around COVID infection. We haven't had one here, and we haven't had one in any of the private clinics, but we wanted to be prepared to give clinicians some structure about how to advise patients if they discontinued a course of treatment or had an interruption of a course of treatment, and how we would deal with that. We will deal with any of those circumstances on a patient-by-patient basis, but we wanted to have some general guidance for staff in helping to address those questions. And if maintenance treatment was being interrupted, we wanted to think in advance a little bit about what we might offer to patients if they couldn't go ahead with TMS. Again, fortunately, this hasn't been an issue, but there are a variety of other interventions that patients might be offered under those circumstances. And then in terms of our clinical research program, we kind of were faced with some other interesting challenges that were probably more relevant to some of the research members of the audience today. So I'll talk briefly through those, being very conscious of what the time is. This is the timeline of kind of our response, really. So a pandemic protocol was enacted by Epworth Hospital in general on the 31st of January, which seems like an extremely long period of time ago now. In early March, we had a period of time where a series of our staff had to go into isolation when there was a suspected exposure from one staff member who then potentially might have exposed the rest of the staff. Fortunately, we didn't have anyone diagnosed, but in a way that kind of prepared us so that we, by the time late March came around where things were really escalating, we had got used to working, or at least had started to develop protocols for working remotely across the centre a couple of weeks before everybody else really had to do this. So in mid-March, in the state of Victoria, an emergency was declared, and we began to wind down our in-person TMS trials. We decided not to recruit for outpatient TMS trials at that stage. So clinical treatment continued both on an inpatient and an outpatient basis, but we felt it was hard to justify patients being enrolled in research trials at that time, particularly given that we were running 2 trials in Alzheimer's disease with more vulnerable elderly patients. And by the start of April, we'd suspended all our TMS clinical trials and done a number of things that Kate alluded to transition as much as we could to supporting remote TACS studies, and have continued 3 of those trials really uninterrupted throughout the pandemic, although with varying levels of intensity of recruitment. We recommenced our outpatient TMS trials on the 10th of June after a long process of consideration and thought. And it wasn't obviously long after that where things started to escalate again in Victoria. We haven't suspended those trials, but are working with all of the guidelines that I described earlier on to maximise safety. During sort of some late February through really to April, we had almost daily meetings to discuss the emerging challenges and to try to synthesise the information we were receiving from Epworth Hospital, from Monash University, and from the hospitals that where most of our protocols go for ethics guidance, because and sort of synthesising all of these guidance to try to work out how best to advise staff took a fair bit of time, as I'm sure most of you are fairly aware. We tried to be fairly proactive and get a little bit ahead of things, and interestingly, within the hospital anyway, a number of our operating procedures were adopted as hospital-wide procedures that I think reflected the degree of work and thoroughness that was put into developing them by the team, including Kate and Sally Herring, who's our research manager, and a number of other members of staff who really meaningfully contributed. We instituted a daily Zoom coffee chat to ensure that our lockdown staff had some way to connect, and that's continued right through, and we've really tried to encourage people to participate in that. It varies from a lot of people to a small number of people, but I think is an important way for people to engage on a daily basis in an informal way to replace the sort of corridor chat that everybody would normally have. And we've really, tried to balance the respect for safety with what we believe is an important principle around the fact that medical research is an essential and ultimately potentially life-saving activity, and any suspension of medical research is going to have health implications in the future. And so there's a value judgment going into that. We've obviously had to be flexible and adaptable, but also try to ensure safety is maximum as we can. So I won't go through these guides. This is some of our internal guidance documents around the use of PPE, the use of cleaning, shared surfaces, et cetera, most of what I described with the clinical TMS and TMS clinical trial activities applies to research environment as well. And we're certainly now pretty much, as I said before, using masks and gloves in particular with any lab-based procedures, and trying to limit the amount of time individuals are within in specific environments. Most of our staff are still, well, all of our staff really, except for me and my admin support, are working from home, except when they have to be in the hospital for a patient visit. So kind of where the sort of key actions along the way were try to ensure uninterrupted clinical TMS treatment. Certainly in the clinical trials that happened, but we're now back up and running it again now in studies in Alzheimer's disease, OCD and autism, and a depression study to commence soon. We have had these slides, even done in the last couple of days, are now out of date, and that we were restricting patients from suburbs under lockdown, but now we're all under lockdown, so that's kind of changed a little bit. And the biggest challenge really going forward is how we recommence some of our student and investigational projects, which really remain suspended, and how we kind of manage patients from different areas. So given that we are well over time, I'm going to finish there. I'm happy to hang around for a few more minutes if anybody's got questions about this, and I'm sure the rest of the panel will do so as well. So I'll finish there. Thanks, Nigel.